Today's session we will be discussing a Government of Kerala guidelines for management of COVID-19 in children. For doctors, there are three sections. One is management of acute COVID, second is management of MISC, and the third is management of newborn with COVID. So this is a very dynamic document, so it will be updated as and when new evidence comes. This protocol is given basically to make the treatment of COVID in children uniform throughout Kerala. Now, what are the signs and symptoms of COVID in children? Most often there will be no symptoms. So the only reason why the child is tested is basically because somebody else in the family is positive and the child is tested and found positive but without any symptom. So that is the usual scenario. So 90 to 95% will have either no symptoms or only mild symptoms. If there are symptoms, what are they? They are rhinitis like common cold, sore throat, cough, fever, body ache. Fatigue means you don't feel like getting up, which is unusual for a child. Child is always up and around. So if a child prefers to be lying down, there is something wrong. So diarrhea and vomiting and loss of appetite. The loss of appetite in adult is basically because of loss of smell and taste, which in a child present itself as loss of appetite. As compared to adult, gastrointestinal symptoms and possibly fever are more common in child as compared to adult. But now, what is a serious COVID in a child? Serious COVID is a pneumonia presentation, pneumonia-like presentation. Serious COVID pneumonia is very unlikely in a child. The reasons are two. One, the COVID organism binds to ACE receptors, which is actually not very abundant in the lung tissue in a child. So it largely remains an upper respiratory infection rather than a pneumonia in a child. And the pneumonia, COVID pneumonia in an adult is peculiar in the sense there are thrombosis in the pulmonary circulation also. And that contributes to ventilation perfusion mismatch. For a child, the vessel is very smooth. It is a young vessel, very smooth. So the blood flow smooth. But in an adult with a lot of plaques inside, there is a tendency for a thrombus formation in a condition which is thrombogenic. So the possibility of thrombus formation is with the adult and not with the child. So the ventilation perfusion mismatch that is seen in adults is also less likely in a child. So pneumonia is less likely and less dangerous in a child. The second serious thing in a child is multi-inflammatory syndrome in childhood. That is MIS-C. That generally occurs about 6 weeks after, 3 to 6 weeks I would say, after acute COVID. Unfortunately, it may follow mild and totally asymptomatic COVID. So much so, when a MISC patient comes, you may have to take the history and see whether somebody else in the family was affected. And early identification of MISC is also very important because it is basically a treatable condition. So as per this protocol, the government is going to give an instruction that JPHN keep a line list of all the involved COVID affected children in their area and follow them up for 3 to 6 weeks. So much so, all the early signs of MISC may be picked up and the child may be brought for evaluation to a pediatrician. Now, how to categorize this COVID? We categorize for segregation, we categorize into A, B and C. And what is A? That is a mild sore throat, cough, rhinorrhea, diarrhea, vomiting, but without dehydration, and no fever. Because when a child is running fever, it is always better that we evaluate for cause of fever. It need not always be COVID also. Now, what is category B? Category B is high grade fever. And what is high grade fever? You give paracetamol, but the fever recurs in 4 or 5 hours again. So that is high grade fever. Normally, once you give paracetamol, for about 6 hours, you must be fever free. The second thing is a fever with chills, which also indicates a high grade fever. And severe sore throat. What is severe sore throat? That means the child is unable to take food, refuses food basically because of the painful throat. So that is severe sore throat. And severe cough. What is severe cough? A child who cannot talk a full sentence, in between he just will have to interrupt the sentence for cough. So that is severe cough. So these people come under category B. The second type of category B is a category A patient but having comorbidities. For example, a chronic kidney disease. So acute nephritis last month is not a significant kidney disease, but a child on dialysis is, yes, it is a comorbidity. Liver disease, again chronic liver disease is a comorbidity. And malignancy, any malignancy is a comorbidity because it affects our immune system as well, both treatment and the disease. And long-term steroid and any other immunosuppressive therapy. So that is also comes to category B, even though the symptoms are category A. And any child, even if it is B or A, symptoms are persisting beyond 5 to 7 days, again must come to category B. Because basically we expect the symptoms to come down in 5 to 7 days. If it is not coming down, we must know whether it is because of some other disease or this disease is taking a worse turn. So that is why they are categorized as category B. Now what is category C? Anybody with danger sign is always category C. And what are the danger signs? Breathlessness, inability to feed. Inability to feed means if you are breathless, you will not be able to take feed continuously. You will have to stop in between. And being breathless on normal activities. Then these are all actually related to our lungs. And then altered sensorium. You feel like fainting once you get up. You become lethargic, always sleepy. These are all possibly related to decreased oxygen supply to the brain. And hypotension. If the BP is low, either compensated or decompensated, whatever it is, that should come to category C. A compensated hypotension that is not better with one fluid should come to category C. And SpO2 less than 94 is also category C. Now, when a doctor categorizes patient, it will be depending on the severity of the disease. Since the doctor is assessing, it is slightly different from the A, B, C that we have already described. So a doctor categorizes it depending on the severity of illness. So that is mild, moderate and severe. All category A and B are mild, but then doctor can use his discretion, because for example we will go back to the categories now. See, category B, having a high fever, the doctor evaluated and decided that the child can remain at home, can be sent home, need not be at hospital. At the same time, a child on dialysis is becoming breathless. So it could be because of his kidney problem also. So that child may need hospital care. So that is why the doctor will categorize it depending on severity. So mild is, simply speaking, it is fever, sore throat and rhinorrhea. And what is important is there should be no hypoxia or breathlessness, which means all the illness is in your upper respiratory tract. Your lung is yet to be involved. So that is mild. In this mild, you can have either category A or category B. Hope it is clear. Now, what is moderate? Moderate is you are having tachypnea, or you have breathlessness, or you have an SpO2 that is down, but within 90 to 94. That is moderate. So moderate actually is category C, but not having any danger signs. So that is the difference between moderate and severe. Both are category C. So category C is a COVID child having tachypnea, breathlessness or a drop in saturation but within 90 to 94. So that is clear. Now what is severe? Severe is your SpO2 is less than 90. There is hypoxia, hypotension or organ involvement. All these three, any of these three will automatically push the child to severe category. And danger signs. Again we described in the last slide, inability to feed, grunting, chest indrawing, all these things point towards a respiratory issue that is severe, or altered sensorium, lethargy, seizures, somnolence, all pointing towards your decreased oxygenation of the brain, or as we said in the previous slide, hypotension, ARDS, or multi-organ dysfunction. These are all categorizing the child to a severe category. Now, where will you treat all these patients? A symptomatic child definitely can remain at home, but sometimes there may not be enough facility for isolation of the child at home. In that case, that child can be transferred to the dedicated COVID ward of a taluk hospital. And anybody having category A symptoms also must be in taluk hospital. And the reason why they are in taluk hospital is, in taluk hospital there is always a pediatrician, so much so at least once a day the child will be evaluated by a pediatrician. See who is category B? Those with high fever, severe sore throat, severe cough, or those with comorbidities, or which is not settling in the 5-7 day interval, they must come to district hospital. Category B must come to district hospital because you need a little bit of investigation, and because of this breathlessness he or she may require oxygen support and continuous monitoring, and that's why we are preferring district hospital. And regarding category C moderate can be kept in district hospital where there is a high dependency unit, HDU. And category C severe and also MISC must come to medical college, that is the tertiary care center. Now what is this HDU, high dependency unit? It's nothing big. You have somebody to monitor, a human monitor always there, and a pediatrician available, and you have a facility to give oxygen. Even with cylinder oxygen we can give oxygen by face mask or nasal prong or CPAP, etc., and pulse oximeter to measure saturation. So that is all that is needed for a HDU unit. So it is not a big issue. Now what is PICU, pediatric intensive care unit? This is where you have a trained staff. Second, multi-para monitors are there. Third, you have facility for invasive and non-invasive ventilation, and you have infusion pumps for the accurate delivery of drugs, especially inotropes. Now coming to the treatment of acute COVID-19 infection. Mild disease we said taluk hospital or sometimes home care. Moderate disease we said designated district hospital, and severe disease we said district hospital with HDU or a tertiary care center. So for mild disease you need only symptomatic treatment. And what are these symptomatic treatment? So before that, what is mild? No hypoxia, no breathlessness. So that is mild disease. Mild disease, how do you treat? It is symptomatic treatment. And what is the symptomatic treatment? Paracetamol 10 to 15 milligram per kilogram per dose, may repeat 6 hourly. Lot of fluid, because in fever you sweat a lot, you need good hydration to normalize temperature by perspiration, and as far as possible avoid other NSAIDs. And next is good rest and sleep, very important, because your body, when you are sleeping, all the metabolic and other activities of the body are at minimum, so everything is spared for fighting the infection. So sleep and good rest is very important. Next is the balanced diet and some vitamins like vitamin D, which is shown to help. So it is not that the balanced diet will cure COVID-19. It is not that balanced diet is a method of curing COVID-19. No. When your diet is inadequate, your immunity actually comes down. That we know from study of malnutrition cases. So we want the nutrition to be at its adequacy, and that's why this balanced diet. Now if there is diarrhea, you can give ORS, zinc, but unnecessary zinc is not encouraged. Child with cough, what to do? Cough syrups are of doubtful value, and many of these cough syrups do have antihistamines. So this sedation will adversely affect our assessment of the child, and hence better avoid. And prone position can always be encouraged, basically because in prone position, our oxygenation at the back of the lung, that gets much better. So we can open up the alveoli, which otherwise may be lazy and closed. So intermittent prone position, as much as tolerated, must be encouraged. Avoid cold exposure, especially over the chest, because we all know somebody who is prone to get pneumonia, a cold exposure to chest may enhance its occurrence. So avoid that. Steaming is not beneficial, because steaming means steam itself means it is beyond 100 degree, and then once the steam comes and lodges on your mucosa, it will release all the latent heat of evaporation. So much so, there is a fair chance of mucosal injury. And mucosal injury is unwelcome, because it can lead on to some innocent organism getting a foothold there. So it is preferable that you do not encourage steaming. No role for antivirals or antibiotics, except when you suspect a bacterial infection. And no investigation is needed for a mild case. So when should you refer a mild case to a higher facility? Fever that is lasting for 5 to 7 days, a cough that is worsening beyond 5 days is one reason. Basically because we must assume that the viral multiplication, which is supposed to come down by day 5 to 7, is actually not coming down and possibly going up. So we must refer that particular child. And if the child is on home care and this fever is not subsiding or the cough is increasing, then he should go to Taluk hospital. If the same thing is happening while the child is already in Taluk hospital, then he should go to the district hospital. And before sending to the district hospital, the Taluk hospital pediatrician should do a physical examination to look for alternate cause of fever. For example, it could be a urinary infection. And minimum investigation also we can do, for example, complete blood count and CRP. Now, if a child is in Taluk hospital and the pediatrician is detecting danger sign, then he can be directly referred to district hospital or even tertiary care medical college. But stabilize and refer. Suppose the child has developed a seizure, control seizure and send. Suppose the saturation has fallen to below 90. Give oxygen and make sure that the child is referred with oxygen. So that is what I meant, stabilize and refer. Now what is moderate? We have already seen that somebody having tachypnea and breathlessness or breathlessness, SpO2 between 90 and 94. Again, we must not put a lot of emphasis in SpO2. For example, SpO2 is 96, the child is very breathless. That means the child is keeping this saturation at the expense of extra effort. This child is going to decompensate very soon. SpO2 is a very important parameter, but we should not place a lot of emphasis on that. You must give preference to your clinical impression. So moderate, I said, must be ideally in a district hospital. Why? Because there is a HDU facility. Now, treatment is paracetamol, as we said earlier, but sometimes we may have to give rectal also, because child may not be taking orally or may be vomiting. And at times, this breathlessness may not be due to COVID. It could be reactive airway disease. So look for wheezing, and if there is wheezing, don't hesitate to give salbutamol by metered dose inhaled. Then diarrhea, ORS and zinc, maintain fluid and electrolyte balance, oral intake or nasogastric or IV, whichever is feasible or acceptable to the child. Now if SpO2 goes below 94, of course you must give oxygen immediately. Generally we start with oxygen by prongs. Face mask is another option, and we must target SpO2 between 94 and 98. And consider intermittent proning. Ask the child to lie prone intermittently, because that will enhance the aeration of the basal segments of the lung. Amoxicillin generally is given if there is a suspicion of infection or in a small child. In a small child, it is always difficult to say whether there is an infection, bacterial infection or not. But generally, you do not go to higher antibiotics. Amoxicillin or ampicillin is enough, because the COVID child is always isolated and there is hardly any chance that secondary infection comes from somewhere, or hospital acquired infection etc. are unlikely. So if the child is getting infection, it is possibly from his own colonized organism in the nasopharynx or so, which is likely to respond to amoxicillin, and that's why we stick on to amoxicillin. Now, what are the COVID specific treatment that we can give for moderate? Suppose the child is having a significant fever or cough beyond 5 to 7 days. There are two possibilities. One is the viral multiplication is going on, which is less likely in an immune competent child. Or your immune system has produced a lot of substances like cytokines to take care of the virus, and virus is now settled, but cytokines are there and it is getting produced again, and so there is additional inflammation causing the fever. So these are the two possibilities, and hence since in an immune competent child we do not expect the virus to be multiplying in a significant quantity at this time, that is beyond 5 to 7 days, generally we must give steroid, methylprednisolone 0.5, the very small dose, 0.5 milligram per kilogram per dose, or equivalent dose of dexamethasone or prednisolone. Ideally, steroid is required only for a patient with hypoxia, but if you clinically feel that this child will deteriorate, then always start early, rather than waiting for the hypoxia to be documented and then give, because it is always hit early works better. Now, this prednisolone dose that we are giving, or methylprednisolone that we are giving, it is not for MISC. MISC is a totally different thing that comes after 3 to 6 weeks. This is after 5 to 7 days. You find that the child is not responding the way the child is expected to, and hence you think there is a over action of our cytokines or immune cells, and we want to subdue it, and hence we are giving a small dose of steroid. And that was why during earlier Kerala protocols we used to give hydroxychloroquine. Hydroxychloroquine is an immune modulator which we give for SLE or rheumatoid arthritis, etc. The problem is it is a mild immune modulator, and then it takes a long time to get the effect. It gets a long time for the effect to be seen, and hence hydroxychloroquine started early in the course of the disease. So by 5 to 7 days, the hydroxychloroquine has got a slight immunomodulatory effect, so that your body do not overreact, and that was the reason why we have been giving hydroxychloroquine earlier. Now all protocols have done away with hydroxychloroquine, and so we are also taking it off. And basically steroid is a much potent immunomodulator, of course. So once you decide on steroid, then possibly there is no role of any other immunomodulator. Now, investigations for all moderate, no. Only if there is persisting symptom, hypoxia, or to rule out alternate diagnosis. For example, dengue. Now that rainy season has come, dengue may coexist. So one or two simple investigation will give a clue. For example, a very high ESR we do not expect in dengue at all. It will be something like 20 or less in dengue. High hematocrit, which means again it is dengue rather than COVID. If we are deciding on investigations, the investigations of importance is, one is complete blood count and second is CRP. All the other things of course can be done, but these are the two priority investigations. Chest X-ray of course you can take, but in a moderate means it is an early stage. Early stage, these things are likely to be picked up in CT and not really in X-ray. If facilities are available, you can do other investigations like D-dimer, ferritin, liver and kidney function tests. When will you refer to a tertiary care center? There is an increased work of breathing even with oxygen support, because in moderate we are already giving oxygen support either by nasal prong or by face mask or even CPAP, but there is increased work of breathing or work of breathing worsens or the saturation drops to less than 94 in spite of oxygen support. They should go to a tertiary care center. Then hemodynamic compromise, even a compensated shock, if not getting better with fluid bolus, should be referred to tertiary care. Then organ dysfunction, altered sensorium. Altered sensorium is again an organ dysfunction, the brain dysfunction because of lack of circulation or oxygenation. So the most important thing is stabilize before referral. Now severe disease, that we have already discuss what is severe. Any case with danger signs or saturation less than 90, organ dysfunction or ARDS like progression. All these things warrant admission to a tertiary care center. And in tertiary care center, they must be admitted in ICU or HDU. Because if our referral criteria is strict, then all the patients coming to a tertiary care center will require minimum HDU and 1 in 3 will require ICU. Now what are we going to do? If SpO2 is less than 90% on nasal prong, the options would be like face mask at more than 5 liters per minute will provide FiO2 of at least about 40%. Oxygen hood, small oxygen hood, a flow of 5 liters per minute. For a bigger oxygen hood, you will require flow higher than that for carbon dioxide washout. So if one side port is closed, it will provide 60%. If both side ports are closed, it will provide 90%. And Venturi mask has got no additional advantage, so we are not using it. Non-breathing mask is very good. At a high flow rate like 10 to 15 liter per minute will provide around 90%. High flow nasal cannula is a good option. As a precaution, we use surgical mask over a nasal cannula so that a rapid jet of air with organism will be prevented. And if we are using head box, then the side ports can be covered with surgical mask again to prevent this rapid high velocity flow of organism rich air. But once you apply the surgical mask over the side ports, then it will come out through the hole at the area for neck, which will get subdued in velocity, so the rapid jet problem is over. If there is no response in HFNC in 1 hour, go for non-invasive ventilation. And non-invasive ventilation is less tolerated as compared to HFNC by children. And if there is no response to NIV in 1 hour, go for invasive ventilation. This 1 hour is an arbitrary cutoff. Of course, the ICU team will decide whether we can go on with NIV for a longer period of time or should we shift to invasive ventilation. For invasive ventilation, we use low tidal volume like we do in many other conditions in children. Optimal PEEP cuffed endotracheal tube, and restrictive fluid therapy. Cuffed tube is now available even for a small size ET now, so it's not a big issue. If there is no response to invasive ventilation, the other option is ECMO, which is currently not available in government medical colleges, but it is available in Kerala in some of the private institutions which provide critical care. And shock management is like any other shock with fluid boluses and inotropes. You generally start with adrenaline and do noradrenaline if needed. Empiric antibiotic is a must because in a seriously ill child we can in no way be sure that it's not an infection. And parenteral steroid for 5 to 14 days. Because if a child is with acute COVID is deteriorating, there are only two possibilities. One is an unrestricted viral replication, which is very unlikely in an immunocompetent child, or body's immune reaction like cytokines are overexpressed. So much so there is a lot more of inflammation, lot more of interstitial inflammation of the lung. So it will have to be mellowed down, and hence steroid is used. We give methylprednisolone double the dose as compared to our moderate category. It is 1 milligram per kilogram per dose twice a day, or a comparable dose of Dexa can be used. And as I said, the second possibility is unrestricted viral replication. So remdesivir is to be considered, although it is not a very preferred drug nowadays. And restrictive fluid therapy, which we have already mentioned. Proning is very important even in a ventilated child. Remdesivir has got no mortality benefit because basically it is an antiviral drug, so it has got to be given in the first 3 or 5 days, which is impossible because an adult course will cost 30,000 rupees. So for a totally mild symptomatic person, who is going to spend 30,000 rupees? So naturally we hold back and give only if we suspect unrestricted viral multiplication. That is when the child has come to the serious category. So when you give remdesivir in that stage, the benefit is not much. The dose is 5 milligram per kilogram first dose, followed by 2.5 per kg once a day for 4 days. And it should be avoided in renal and especially in liver dysfunctions. Remdesivir is never to be given beyond 10 days because beyond 10 days we do not expect a viral multiplication to be going on. And investigation, of course, in a tertiary care center, all investigations will be available and can be done. But the priority one would be CRP, D-dimer and pro-BNP. And imaging, if it is available, CT is preferable. And a bedside echo is always preferable because it can assess the contractility of the heart, and also big thrombus can be picked up. But coronary dilatation, aneurysm, etc. will have to be picked up by the cardiologist. So we may have to request a cardiology echo the next day. This is the monitoring chart, whether you are in a critical care. Critical care, of course, monitoring chart will be much bigger than this. But this is a common monitoring chart for all COVID patients. Breath rate, feeding, urine output, danger signs and SpO2. Marked 3 times a day. Discharge policy for children. Children who has been in ICU or ventilator must be afebrile and asymptomatic for 72 hours before discharge. But this doesn't apply for a moderate or a mild category who are in a district or taluk hospital, where the clinician can discretion, although the recommendation is this one. And whether you should do a COVID test on discharge? No. But for a severely ill child who has been in ICU, we do rapid antigen on discharge. The reason is a severely ill child could be basically because of the delayed clearance of the virus. That is one of the reasons for the severe disease. So to make sure that the antigen is cleared, we do the test. So that is mild and moderate category, it is not necessary at all. And the government recommended quarantine must be adhered to, that is total of 17 days if you have not tested. In a severely ill child, this can prolong to 21 days. And hope this session was useful. Thank you very much for listening.